I'd like to therefore introduce our first speaker. This is Toni Flanagan, and Toni is Head of Clinical Education and Quality at St Giles Hospice Care, who's going to be talking to us about getting the terminology right. So over to you. Thanks, Toni.
Thank you. If you could just let me know when I share my screen if it's actually sharing, because I hate yeah. Oh, hang on, let me get it up. There we go. Hate Zoom.
Yes, that's that. You're just on. Yes, if you want to put it on full screen now, if you go to your slideshow, and
you got it.
Absolutely perfect. Thank you.
Excellent. Thank you for inviting me to speak today. So my session really is about setting the scene for the day, really, and hopefully just putting a few things out there for you to consider. Just way of disclaimer, I am not an expert in tissue viability by a long stretch, but hope I'm getting towards being an expert within palliative and end of life care. So what I'd like to do really is share some of my experiences this morning, and maybe just challenge you to think potentially about wound care within palliative care, perhaps a little bit differently as you go through today. So we're just going to start with our terminology. And often people think that palliative and end of life care are the same thing. And so what I'm going to do is share with you the most common definitions around palliative and end of life care, and how they are similar, and potentially how they are different. So if we start with palliative care, so this often surprises people, but the World Health Organization's definition of palliative care is actually quite robust, and one might say lengthy. But palliative care is an approach, so it's quite different to other areas of medicine, in that it is a philosophy and an ethos almost. It's a way of working. So it's an approach that where we're really trying to think about how can we improve the quality of life of patients and their families, and that could be through the problems that they face with any life-limiting illness. So those could be things like advanced metastatic cancer, it could be COPD, it could be MND, MS, interstitial disease. You know, there's lots of different diagnoses that are palliative, and therefore there are lots of associated problems with them. And palliative care aims to improve very much the quality of life. And there are some key kind of cornerstones that the palliative care sits on. The first one being that early identification and impeccable assessment and treatment of pain and other problems. So that first cornerstone is very much that impeccable assessment. And whenever I give palliative care teaching, you know, I stress this point a lot. But actually, you know, we can only treat things however we treat them if we've got our assessment right, and especially with some symptoms such as nausea, vomiting and pain, we can actually go off down a wrong track if we don't do our assessment correctly. The other thing is around this holistic care. So really looking at things from not just a physical point of view, a psychosocial and a spiritual point of view. So really trying to think beyond just what a symptom or an issue might be in the physical, but go beyond that within psychosocial and spiritual care as well. So palliative care, we've talked about the symptoms, but it's very much about affirming life, and we regard dying as a normal process. So we don't want to hasten death, but we don't want to postpone it either. So it's very much, I suppose, letting nature take its course. We've talked about the kind of like the holistic aspects of palliative care, but it's very much about helping people live as actively as possible until death. So what is important to that person, and then how can we support that person to live the life that they want to live until they die. As well, one thing that makes palliative care a little unique is that ability to care for family as well. So family and friends, both whilst the patient is unwell, but then into bereavement as well. And again, that's another area that makes palliative care unique. Um, it also kind of highlights the fact as well that palliative care can run alongside other therapies. So it's not like the American system. So the American system is very much once you're palliative, that's it. you're not allowed anything else, not even an antibiotic or anything like that. And that's because of their kind of private healthcare system. Over here, it's different. We have palliative patients who are still having chemotherapy, they're still having radiotherapy, they're still having immunotherapy. We will still give appropriate treatments to people who are in the palliative phase. So that doesn't mean that we give up on people. If someone is palliative, it doesn't mean that they have potentially less options or that we're not going to do anything. It's just that the way that we do things will very much focus on that quality of life. And then end of life care, luckily, is a bit of a shorter definition, but is a bit more around time. So a person is approaching the end of life when they're likely to die within the next 12 months. So that includes people who are, say, a few hours or a few days away from death. So one way to think about this is all end of life care patients are palliative, but not all palliative patients are at end of life. And that's ultimately the distinction between the two. So when you're thinking about your palliative patients, it would always be useful to think, and we use the surprise question, would I be surprised if this person died in the next 12 months? And if your answer is no, I wouldn't be surprised, then actually you can consider them as end of life. And where considering people at being end of life is useful, is that hopefully then we can do some planning. We can be doing some advanced care planning with our patients and their relatives, maybe starting to think about the future in terms of what their decisions might be if they were to lose capacity, and really just starting to prepare people really for the fact that that time might be short, and what is important to them, and what would they want to focus their time on. How can we improve their quality of life for the time that they have left? So that's kind of like the main difference between palliative care and end of life care. Just to pop up hospice care, just because again that is slightly different. So hospice care hospice is an ethos. So a bit like palliative care is an approach, hospice is an ethos. So hospice, the current hospice movement, I'm sure you're all aware, was started by Dame Cicely Saunders, and it's very much her vision in terms of what hospice care would be. Which is then spread across the world, but definitely over kind of the UK, and has led to kind of like the hospices that we have within this country now. It's really quite interesting where hospice comes from. I've just started my PhD looking at one aspect is looking at this and trying to track back how hospice started all the way back 2,000-3,000 years ago. Is really quite interesting. But this modern hospice movement is very much around affirming life and death. Hospices are part of their local community. So often when we make decisions as a hospice, we will look to see how will that affect our community. It's more than just a building or the services that we provide. Like I said, it is an ethos, a way of thinking. And again, most hospices will provide services for those who are palliative and at end of life, and will often provide, but not all, but will often provide some kind of bereavement service as well. Again, what makes hospice care unique is, or maybe not unique, but one of the special things around hospice care is this multidisciplinary approach. It's this understanding that no one person, no one role can meet the needs of an individual patient and their family, that actually we all have a role to play in the care of that person. But very much at the centre of this is this holistic care as well. So really taking from that palliative care definition around that physical, emotional, social and spiritual understanding of everybody, and how that would be different for everybody. And therefore, that's why we need to have this multidisciplinary team approach. So when we think about tissue viability in palliative care, there's actually quite a lot to think about, and I've only got half an hour, so I really just wanted to kind of set the scene in terms of some of the things that you might want to think about as you go through today. But one aspect would be that holistic care element from palliative care ethos, which is actually any even if you look at any of these pictures, on the right, and they're not all palliative, they're just ones off Google, but you can see there will be an impact on the way that this person will then live their life, whatever that wound is. And therefore we need to think about, well, what would that holistic impact potentially be in the context of someone who is palliative and or at end of life. Something to think about in terms of expectations. So, and whose expectations, are people expecting for their wounds to heal? Are they expecting them to get worse? What is their expectation of you as a caregiver? Thinking about, what are the treatment options, and they may differ depending on where the person is within their disease trajectory. It might change, be different depending on their values, and what is important to them at the time. A little bit about thinking around comfort versus cure. What is the aim of our treatment? So whilst we've got our treatment options, we need to think about, well, but what are we trying to do here? What is the aim for this person at this time? And that may change as they change throughout their disease. And then whose role is it? So we all have a role to play, and actually we could all be playing a role, even your potentially psychotherapist, your physio, your OT, and that comes back to that multidisciplinary way of working, and the fact that actually it might not just be the nurse or the district nurse or the tissue viability nurse, but actually it might need a holistic viewpoint and a multidisciplinary viewpoint. So I just wanted to start really just by looking at that holistic care element. So holistic care, generally, we have 4 areas. So we have the physical, psychological, spiritual, and social. And what I wanted to do was just kind of think of that from a kind of wound care tissue viability point of view. And like I said, just to kind of set you up for the day, really, in terms of when you're going throughout your different speakers, is trying to relate it back to this. If you can. So when we think about our physical well-being, obviously we've got symptom management, or a lack of symptoms. So when we think about how this might impact on our patients, if we've got, and I know I've had patients before who have shortness of breath, or they've got pain, or they've got nausea and vomiting, and that can affect therefore the way that they are concordant or comply with some of the things that we ask them to do, such as being turned, such as getting off their bottom, such as getting their heels lifted off. So all of those, so symptom management can have quite a big impact sometimes on the way that we manage skin. And I know with some patients who potentially do have symptoms such as pain, where they find a single position really comfortable. So perhaps it's lying on their left hand side, and as much as we try and get them to kind of come off that left hand side, that is where they're most comfortable, and sometimes then they do get skin breakdown in those areas. Sometimes as well, symptoms can stop us doing a proper skin assessment, potentially as often as we would like. And again, that can be due to the patient being uncomfortable, and then wanting to be in certain positions. The lack of symptoms I've put in there because I had a gentleman a number of years ago now who was actually referred to the hospice due to his pressure ulcers. He had really big pressure ulcers in his sacral area. He was quite a large gentleman. We'd put him on a tilt bed for all of, I think, about half an hour before he demanded that he was taken off. And I went in there to try and explain to him, the reason why it was important that he was, on this bed, that we thought it was the best thing. And the crux of the conversation was that he turned around to me and he went, "You nurses, you keep going on about all these wounds on my bum, but actually there's no pain. So how bad can it be?" And I was kind of like, but there's no pain because there's no pain receptors left. Your wound has gone through that skin, so that actually there is no pain because your pain receptors no longer exist. And although he gave me that look of really, he then went back to, no, if I'm not in pain, then I'm coming off this bed. So it's almost that lack of symptom, that lack of pain, that kind of informed him that actually it wasn't that bad, and we were all just, making it worse than it was. Um, Skin assessment as well, as you know, vitally important, and viewing the skin is really important, but that can be problematic sometimes, like I said, in context of those symptoms, in terms of being able to look at that. We also need to think wider with our physical well-being. So things like, you know, nutrition, movement, sleep, fatigue, cachexia, really trying to think about what is normal towards end of life as well. So when we're thinking about nutrition and movement, we tend to see people move less and eat less as they kind of go towards end of life, but really trying to think about how we can maximize what they are eating, maximize what they are moving. Potentially sleep and fatigue can have quite a big impact as well, and obviously cachexia. So again, I've had a patient who's been so cachexic they've literally looked like a skeleton in the bed, and their skin broke down massively. I've never seen it before, I've never seen it since. We actually had to throw away the mattress in the end because her skin had broken down that much that it seeped all the way through. It wasn't very nice to watch, but it was just that natural progression, really. When we also think from a physical point of view, is thinking about, you know, those usual things, you know, advice, equipment, support. We know that sometimes advice isn't always followed, it's not always understood. It's really important that we use plain English, that we think about our literacy, our health literacy. You know, the average reading age of someone within the UK is 8. So we really need to think about the way that we give information to people so that they can understand and then make an informed choice. And again, equipment. Often we put our patients on an air mattress, and especially if they've got nausea and vomiting, it makes them feel seasick. So they'll ask for that to be removed. So again, it's just trying to think about what is useful in the context of that individual patient, and what else could we try instead. The other thing with equipment is also, you know, people want to move themselves around, they want to maintain their independence, and actually they might not want a hospital bed because they want to sleep with their husband or wife because that's what they've been doing for the last 50 or 60 years, and actually they don't want to sleep in a bed on their own. They want to be comforted by having that person next to them. And again, it's looking at, well, how can we support that as well? Those are some of the and by no means all of the physical things that we can be thinking about, but they are some things just to kind of get you thinking. When we think about psychological well-being, as we know, this can have a huge impact on our patients. Things like anxiety and depression. It can affect nutrition, it can affect movement, it can affect how concordant our patients are, it can reduce independence. It can also, in the context of tissue viability, people again can go into those positions where they don't move very often. They don't see the point of kind of looking after oneself in terms of getting up and about, in terms of moving around, and kind of getting that pressure relief, and also sometimes in terms of bathing as well. So really trying to understand where that anxiety and depression is coming from, and seeing if we've got the ability in the time that that person has left to do some work around that. Got to think as well about the impact on ADLs. So when we think about someone having a wound, and we can think about, well, how is that going to affect the way that they live their life, then actually it can have a huge impact. So this could, for example, stop someone going to the pub, which they normally like doing, or go to the hairdressers, or things like that. And again, that can be due to perhaps odor or body image. So, you know, a lot of times people will talk about the fact that a dressing can be seen, and therefore they don't want to go out and about like they normally would. If they've got something like a fistula, then actually that's going to be really quite difficult potentially to manage, and therefore how does that affect the way that the person views themselves? From an odor point of view, and definitely from a carers and family point of view, I remember having a grandson who was there with his mom, and his grandmother was in the bed, and his mom said, go kiss granny, and he went, oh, I'm not kissing her, she smells. And she was coming towards the end of life, so the fact that actually, what could potentially have been her last kiss from the grandson was kind of stopped because of that kind of odor. So we can't kind of underestimate the impact that has on our patients, and often they know um, that that's there. I've had patients apologise repeatedly. I'm so sorry it smells. I'm so sorry it smells. And although we try and do things like use cat litter under the bed, or use essential oils, things like that, they are quite strong odours often that are quite recognizable, and therefore are hard to sometimes get rid of. So it does have a psychological well-being impact on that person, and family and carers sometimes stop coming around also because of that smell as well. So again, it can have that big impact from a psychological point of view. And again, I remember a lady a number of years ago who had fistula. She had a rectovaginal fistula that was constantly draining. It used to take us about 2 hours to kind of dress and pack, and then have to repeat it about an hour later because it was just so profuse. And you saw her brother eventually stopped visiting. The time between visits just got less and less and less, and actually I don't think they saw her for about the last 2 weeks of her life, and that had a profound psychological impact on her. She very much just turned away and kind of gave up. It had quite a big impact on that. From a social point of view, the financial impact, so things, especially at the moment, things like clothing and bedding. So again, with exudate, and especially if things are leaking, then that kind of having to buy extra clothes or cut clothes, bedding, slippers, those kind of things, and having to kind of adjust the way that we do things can have a financial impact. Somebody might not be as mobile anymore, so might need taxis, so obviously that costs more. So just trying to think about the financial impact that these kind of things can have. I think especially with that exudate, the amount of washing there would be, especially within the current climate, where actually that could have quite a big impact. That socializing aspect, it could be limited, it may not be, but it could be, and that's either with the patient actually going outside of their home, which obviously enables them to feel less isolated, or people avoiding going to them. um, and that again can have a really big impact on people's psychological well-being, but also feelings of isolation, and togetherness, as it were. Housing as well, again, something to consider. Not all houses have that ability for a hospital bed. Not all houses have that ability for large stocks of say dressings and things like that, or for all the aids that we'd like somebody to have. So it is really about thinking about what is possible in that person's own home, but also what they would like to have within their home, so that it remains a home, and it's not just a bit of a satellite unit from a hospital. Also thinking about that waste disposal. So again, if you do have large amounts of exudatus, kind of dressings, what are we doing with that? How is that home kind of disposing of all that waste? Especially these days where you get your little black bin, um, and it gets emptied every 2 weeks. For a normal family, you would normally fill that up, but actually if you're getting all this extra waste on top of that, where is that going? Is that actually you know is that actually able to be gotten rid of in a normal way, or are people doing like tip runs and stuff like that? So again, it's just something to think about. um, and again, the clothing, shoes, and slippers, less of a financial impact, but more of a, we all have an individual style, the things that we kind of like to wear, the things that we kind of like to do. And actually, our wounds or the things that we have may affect actually the clothing, shoes, slippers that we would normally wear. So we might have to wear things that we wouldn't have worn years ago. And actually, that can have a psychological impact as well, in terms of, am I still me, if I'm not able to project me going forward. So really trying to think about that, as separate to the financial impact of having to buy them, but as a projection of self, and how we might present ourselves to others, who and yeah, how that the impact of potentially changing that would have on our psychological self. And then from a spiritual point of view, these tend to be the questions of why me. So actually, if we're talking about skin damage, that often will be on top of an existing burden, within palliative and end of life care. So not only have I got this disease and these symptoms associated with this disease, but now I've got this as well. So why me? Why do I keep having these extra things put on me? So again, that can be something that can kind of slightly cross over into the psychological, but those why me questions tend to be very much within the spiritual domain. Total pain. This is a concept that Dame Cicely Saunders came up with. The fact that pain can be total, that you can have pain within the spiritual, psychological, and social elements, as well as within the physical element as well. It's a really interesting concept, and they all kind of impact on each other. So we know, for example, and I'm sure you do as well, that actually if you've got pain, but you're also going through a quite a difficult time in your life, that pain will often feel worse than perhaps if you had that same pain at a time in your life where it's going well. So that concept of total pain, about everything having an impact, is really quite interesting. Um, there is a potential as well that that a wound could be life limiting. So again, if it gets infected, if the person becomes septic, it in itself could potentially limit that person's life, as well as having an impact on their life. It could also have an impact on their life goals and what is important to them. And I have got a story about that, but I know I'm getting close to time, so I can tell you that story in the questions, if anybody's interested. And it is specifically around skin as well.
Toni, we can sort of offer about another 5 minutes on top of what you've got. So if the story is lovely, you know, and please do tell it.
Okay, so we had a gentleman a number of years ago. He was 21 and he had a sarcoma of the thigh. So it was a tumor that was completely treatable, but he had psoriasis. And his psoriasis was actually really bad, to the point where they couldn't do the surgery on his thigh because his skin, they said, just would never recover. It would get infected and he would die from infection. So they never did the surgery. Now, I admitted this patient onto our inpatient unit, and me and the doctor asked him about what his life goal was. And he said he wanted to go to the Vatican. It's quite difficult for me and the doctor, because at that point we had to give that kind of response in terms of letting him know that that was not going to happen. He was too poorly, and we said to him that actually, with the amount of pain that he had in that thigh, he'd never be able to sit down for the flight. So we asked him if there was anything else, and he said he'd give it a thought. He came back to us a day or two later, and he said there was a new movie out at the cinema. I think it was something like Godzilla, and we are going back a number of years. And what he wanted to do was go to Godzilla with his mates. Like I said, his pain was really quite bad, so he couldn't sit down for long periods of time. So we rang up our local cinema, which was in Tamworth. We arranged for them to put on a private showing so that him and his friends could go along and watch it. So that what they would do is have someone in the projector room, they'd stop it if he needed to, and then restart it. It got to the morning of him going to the cinema, and he was in far too much pain, and he said, I can't go to that. So obviously we are a law-abiding hospice, and I don't know how, but we did manage to get a copy of that kind of movie, and we played it in his room and got like pizzas and stuff in for him and his friends. Where how that's important to kind of a spiritual well-being point of view is that concept of hope. So there's a lot of literature out there on hope, and I won't do it justice, but that idea that actually hope changes as you go along, but it doesn't necessarily go away. So he had a hope at the beginning, which was around going to the Vatican. That wasn't possible. So then it was going to the cinema. Unfortunately, that wasn't possible. And then we got to something that we were able to do with him. And that still enabled him to achieve a goal, something that was important to him. And actually, he got good spiritual well-being from that. You could definitely tell in the days following that his pain went down quite a bit before flaring back up. So that kind of spiritual aspect is really quite important around kind of caring for people. Just thinking a little bit about expectations and treatment options, and how that can be varying between from both patients, carers and clinicians, but really trying to think about what is a realistic treatment goal, what are the treatment options that are suitable for that person, trying to kind of look at that palliative care and end of life care, where are they? And therefore what would be appropriate. And it really is that balancing act. And it might be that those treatment options and the treatment goal change as the person changes, and that's okay. But it's just about trying to think about really from the beginning, what are those expectations? Because if the patient and carer thinks that you're going to potentially get rid of something like a pressure ulcer in the next week, and actually that's not going to be possible, then we need to be able to manage those expectations from the beginning. Might also be that we need to manage the expectation that the person will not have any skin damage. That might be an expectation of both the patient and the carer. And again, it could be about having conversations about what is the natural kind of deterioration of the skin at end of life, and what that might look like, even from something such as mottling, going all the way through to potential skin damage. And just lastly, because I am at time, whose role is it? Well, actually, everybody has a role to play, including the patients and the carers. It is about us all working collaboratively and really putting the person at the centre of the care that we give. And if we can try and think about things more holistically, and the impacts that especially wounds can have on the way that that person lives their life, bearing in mind they might have a very short amount of their life left, then actually it might need some quite creative thinking, and sometimes challenging conversations around how we can support people to do that. And I think especially when we think about things like exudation odor and body image and things like that, those are some things that actually we should probably be spending a bit more time considering in terms of the impact of that on someone who is at end of life, and what that could be preventing that person from doing with the short amount of time that actually they have left. Okay, I will end there and I will stop sharing.
Thank you so much, Toni. That was an absolutely incredible presentation, and I just, I'm in awe of what an amazing resource we have in people like yourself, providing such excellent care to patients. The story about the cinema was incredible, and there's been some comments in the chat about that. You've covered so much there. I mean, where do we start, really? So if people have any questions, please do. There's comments in there which you can have a look at, Toni. But I think it's really I think it's important that we do get our heads around definition in terms of palliative care and end of life. And I was just thinking about some of the cases I've had with people, people I think historically have always related this to people with cancer, haven't they? And it goes so much beyond that. And I talk to people a lot about frailty and wound care, and this ambition that we can heal these wounds. And when you look at these people who are frail, elderly, multiple comorbidities, clearly, I think that's a really good thing. Where would you be surprised if they're sort of still living in 12 months' time? And I think that is really important question we should be asking ourselves of the people that we're looking after, and then adjusting our care plans to meet the needs of that person, rather than this we will heal,
Yeah.
you know. Have you got any thoughts on that? How can we do that confidently? Because sometimes we feel we failed if we can't heal.
I suppose I come from it from a different point of view, in that I wouldn't expect to heal in a patient who is at end of life, or potentially palliative, just from the general, what you'd normally have for good wound healing, which is lots of movement, eating and drinking, a well balanced, all of that stuff is often more limited in a palliative and end of life care. However, we do, and you've got Jane talking later, who's our tissue viability nurse, and actually we do heal wounds. So it's not to say that we don't. We do that, but I suppose it's thinking about, suppose again, if you put the patient at the heart of this and ask the patient what is important to you now, and actually if what's important to that person now is doing X, Y, and Z, and the wound is stopping them, then actually there's a real emphasis on, well, how can we maximize them doing X, Y, and Z with the wound management, if that kind of makes sense. And I suppose there's such a wide variety of wounds that someone at palliative and end of life care can have, right? Like you said, very much from that frailty point of view, which might be a pressure ulcer, all the way through to some quite horrific kind of fistula wounds, which are, and fungating wounds as well, which can be a lot more impactful in terms of the psychological point of view and the social point of view, especially I think in terms of odor, body image, and things like that. So I think again, it is that kind of thinking about, you've always got to go back to your patient, haven't you, and think about, well, one, what is their wound? Two, what is achievable? Three, what is important to them, and what would they like to achieve, and what can we do to help them do that? And then your palliative and end of life care will give you the time scale that you've got to work with, I suppose, in terms of, if they're palliative, you might have more time to be able to achieve that, whereas with somebody who's got days left to live, you're going to be going down the what's important to you kind of point of view, and really hammering home with that. So I think it will be so individual to that person, I think. But again, if you always keep the person at the heart of it and what's important to them, then I don't think you can go wrong too much.
No, and I often ask the question, do you want your wound to heal? We there's a lot cited around non-concordance, and I just don't like that language at
Different
all, and I try
priorities.
to discourage that. With therapy. So say for example, someone's got a leg ulcer, and they don't want the compression sort of thing, but I often will ask that question, do you want the wound to heal? And incredibly, there are many people that don't. They're not bothered about that. But as long as you remove the pain, or I can get my shoes on, or I can visit my relatives, or get to a wedding they want to go to the year after. So I think that's where holism comes in as well, isn't it?
Yeah, and I think it's always asking that understanding that why. So why is it that that person doesn't want? So when you're talking about that compression bandaging, I'd imagine that I've never had it myself. Obviously, as a nurse, I've seen it and done it, but that's going to limit mobility. So if I've got to go to if actually what's important to me is going to the bingo 3 times a week, because actually that's my social output. That's the only time I get to see my friends, and that's what's important to me. And that bandaging is going to stop that, then actually what's most important to me is the bingo, actually. So I'll forgo that. So it's not necessarily that they might not want it to heal, but they have something that's competing. And I suppose for us, when we're going in to do a task, which is dress said legs, but that's a task, we're not potentially looking at it from the person's point of view, which will be that impact. So there's a questionnaire that we use, called IPOS. It's a specialist palliative care tool. And the first question is, what are the 3 things that are most important to you? And when they did the research study, they did healthcare professionals basically versus the patient. And the healthcare professionals would put things down like symptoms, so pain, shortness of breath, and stuff like that. The patients would always put it down in the context of them. So I had a patient who said, so one of the main things that was bothering him was, I'm not able to get out into the garden, because he was a really keen gardener. And I said, why is that? And he goes, the pain. the pain was secondary to the garden, if that kind of makes sense. So the important thing to him was the garden, whereas the healthcare professional had put the pain. So it's very much as we go in probably from a more symptom task point of view, whereas a patient will see it more from an impact point of view. What is that stopping me from doing? How is it affecting my life and the way that I live my life? So I think sometimes as healthcare professionals, we need to just switch a little bit from, yes, the pain might be the problem, but what is the impact? And actually it's the
Absolutely.
impact that's important to the person.
And have options, and be flexible with those options, really,
Yeah,
rather than it's this or nothing
yeah,
sort of thing. It's
exactly. So instead
yeah,
of that full compression bandaging, can we do the half? Is there something
yeah.
else that we can get a middle ground that enables you to go out and do what you want to do, but there is still some benefit to your wound as well, although it might just take a little bit longer to heal.
Absolutely. I'm really interested around the no symptoms story you said about the guy that didn't want the turning bed.
Yeah,
And I think we don't really consider that. So when people aren't wanting to work with you on a specific plan, it's a difficult one, isn't it? Because I suppose from a nursing or a clinician's point of view, we can see the consequences of them not having X, Y, or Z.
yeah.
Um, and it can be quite distressing for clinicians when they can see deterioration, and people aren't accepting it because there aren't symptoms, or for what other reason.
Yeah, definitely. And he died 2 weeks later from sepsis. But when I do remember his face still when I told him about the pain receptors, and it was the fact that the pain receptors were no longer there. That's why he couldn't. And the look of shock on his face. And I thought, am I
Mm.
the first person telling you this? Because we got him way down the road. He'd been having other clinicians go in for at least a year or two. And at that point, I think that was the first time he'd been told that, or it was definitely the first time it registered anyway, that was potentially the reason why. But by that point, he was so far down a road, I don't think he would have come back from it, if that makes sense, because he was just that way inclined. But I do remember seeing the shock on his face, as if to say, oh. And I think, again, that goes back to that patient information, that actually people can only make informed choices if they've got the information. And actually, if nobody's said, actually, pain is kind of good at the moment, because pain means that your pain receptors are intact, so what we're going to do is work on that. But actually, once the pain goes, we need to know that, because actually that tells us that actually something bigger is happening, and that kind of thing. So I think some of it is around that patient information giving, but also, again, health literacy is a really fascinating area to look into. But that we have to really think about the way in which we give information to people, and really think about, so it's 8, so the average reading age of someone within the UK, well, England and Wales, is 8 years old. So if you put that in the context of a child, so an 8-year-old would not know which is which.
I
So
can't quite believe that. I
yeah,
really, honestly, that's come as a shock to me.
yeah,
But I think, but also I think, going back to, we'll finish in a second. We could probably talk like this for all day, couldn't we, folks? But I think it's also about the knowledge and skills of the clinician delivering that information, educating the patient. But also it's about the confidence to have some of these difficult
yeah,
conversations. I work a lot with quite junior community nurses who are facing this, in inverted commas, non-concordance with treatment on a daily basis. But I think it's that they struggle with how they address that, how they have those conversations for patients who are just not happy with things.
I mean, Einstein does have a brilliant quote, which is, if you can't explain it to a 6-year-old, you don't understand it yourself. So
Oh, okay.
there is always that, if if you understand the subject matter well enough, then you
Mm-hmm.
should be able to explain it to someone, which is well within that 8-year-old. So sometimes that is a little bit about educating ourselves, and
Yeah.
once we feel more confident, or being confident in what you don't know. So I always say, I don't know everything, but I know what I don't know. So therefore, if someone asks me something that I don't know, like, I don't claim to be an expert in tissue viability at all. So if you ask me one of those questions, I go, I don't know. I'll Jane can answer that later. But it's about knowing what you don't know. So saying to the patient, you know what, I don't know that. and I don't know what the future's going to hold, or something like that, but
Mm.
I can go away and come back,
Yeah,
and I
yeah.
can find out. So it's almost been about confident in what you don't know as well, and that's okay. Patients will respect you for saying I don't know. They won't respect you if you fudge it.
No, honesty. What a great note to finish on. So thank you so much for a fascinating presentation. Everyone, I'm sure, has really appreciated that. So thank you.